Welcome to the new fracture risk scale. I'm Dr. Alexandra Papaioannou, a professor of medicine at McMaster University and scientific advisory council member of Osteoporosis Canada. We're going to, in the next 15 minutes, discuss a better way to assess and manage fracture risk in long-term care. I'd like to acknowledge our osteoporosis strategy for long-term care and the scientists who developed the FRS and the fracture recommendations for long-term care, as well as the staff who supported the development of our tools. Fractures are a serious problem. 2 to 6% of residents sustain a hip fracture each year. Hip fractures are the most common fracture type in long-term care. However, vertebral fractures are also very common, and you can see the curvature of the spine in our two seniors in the picture, which can indicate spine fractures. Over 72% of older adults who are at high risk for fractures, who have experienced a fracture, are not investigated or treated for osteoporosis. The consequences of fractures can be devastating for long-term care residents. Hip fractures particularly cause pain, loss of mobility, reduced quality of life, and contribute to mortality. As well, hip fractures often require a transfer to acute care, away from individuals' homes. Our current fracture risk assessment tools are not tailored for use in long-term care. They predict fractures over a 10-year period and tend to overestimate the number of individuals who are at risk for fracture in long-term care. We have a new fracture risk scale that assesses fracture risk for long-term care residents and the frail older adult, and assists us in putting strategies into place to prevent fractures. The benefits of FRS are it prevents fractures, it can help prevent fractures, improve the quality of life for residents, and improve care. The benefits is it predicts hip fractures for long-term care residents, requires no additional documentation or resources, does not require that the resident is transferred out of the home for BMD testing or bone mineral density testing, and it's been validated across Canada and approved for international use by the Inter-RAI Committee. So how do we interpret the FRS scores? Once the MDS-RAI tool is, the data is inputted, the staff will see that an individual is either low risk or high risk. Those who are low risk tend to be those who can walk in the corridor independently with a BMI greater than 30, or unable to walk in corridor and not fallen in the past 30 days. Those who are high risk are walking in the corridor, have a BMI of 18 to 30, and one of the following: falls, prior fracture, cognitive impairment with a CPS score of 3 to 6, tendency to wander, age greater than 85, or unable to walk in the corridor or had a fall in the past 30 days, or this other high-risk group who are walking in the corridor with a low BMI with or without a fall. I should add the CPS score means those have a cognitive impairment between 3 to 6 using the MDS-RAI tool. So meet Mrs. Andrews. An example would be that she walks independently in the corridor. She has a BMI of less than 18 and has a fall in the last 180 days or 6 months. Her FRS score is 8, which means she's at high risk. Meet Mr. Tedeschi. He's able to walk in the corridor with assistance. He has his walker, has a BMI between 18 to 30, and is over 85. He's cognitively impaired. He scores a 3 on the cognitive performance scale. His FRS is 7, and he's at high risk for fractures. So the CPS is the cognitive performance scale. It's used in MDS to measure cognitive status. Scores range from 0, intact, to 6 with very severe cognitive impairment. Some cautions with the FRS tool. It assesses hip fractures, but it may underestimate the risk for vertebral fractures. The FRS calculates risk based on variables available in the RIMDS 2.0, and other risk factors may exist that are not included. As new modules of the RIMDS become available, we'll update the FRS scale in the future. So where do you find the FRS score for the resident? Look at Point-Click Care. It's embedded in the Point-Click Care is an EMR vendor, an electronic medical record vendor for long-term care. And in the outcome summary report is where you're going to find other scales such as the ADL long form, the CPS, and the CHEST score. The FRS score is generated from data available in MDS 2.0, similar to other scales. Fractures are prevented. You are able to prevent fractures. And so it's really critical that you know who are your high-risk residents so you can integrate osteoporosis prevention strategies with fall prevention strategies to reduce fractures. How will you do this? We developed fracture prevention guidelines using the GRADE approach in 2015, and this was published in the Canadian Medical Association Journal. It was directed at interprofessional teams caring for frail older residents in long-term care, and it really integrates osteoporosis and falls assessments to reduce fractures. Treating residents at high risk. What are the best practices? Recommend calcium, 1,200 milligrams per day, preferable through diet or with a supplement, and vitamin D, 800 to 2,000 international units. Residents in long-term care are often very vitamin D deficient. Consider medications to treat osteoporosis in those who are high risk to prevent fracture if the resident has greater than a 1-year lifespan. Also consider deprescribing of medications that can increase risk of falling. Promote exercise for improving balance, strength, and function. Implement fall prevention strategies such as hip protectors. And most importantly, work as a team with residents and families, combining interdisciplinary care strategies to meet their needs. So what are take-home messages from what we reviewed to date? Regular risk assessment is important. Use the FRS on admission, quarterly, or when the resident status changes. On admission is a particularly good time to ask about fracture history after the age of 50 from the resident and their families. Provide patient-centered or resident-centered care involving residents and their families in the goals of care and treatment options. For more information, you can look at the Jaris Center website or Osteoporosis Canada. We have a freely available toolkit. Are there any resources to assist with risk management in long-term care? You can see here, you can Google around the toolkit, and these are the resources that pop up. It includes videos, it includes PowerPoints, it includes order sets, and also, most importantly, it includes information for residents and families. And here are some examples, best practices around medications, the algorithm about what to do next, and your order set that you can import into your own EMR tools. We're excited that we have these videos that help mobilize residents and keep them functional in long-term care. Their topics are for personal support care workers, physiotherapists and physiotherapist assistants, group exercise trainers and exercise professionals, restorative care. And for those who have never been taught to how to transfer somebody from a chair to standing, there's some really great tips to see on the videos. For residents and family members, we're delighted that the Residents and Family Councils of Ontario develop these informative tools. In summary, to prevent fracture, use the FRS to determine residents' 1-year risk of hip fracture. Develop a care plan to address and determine the risk by promoting teamwork, interprofessional practice, and resident safety. I'd really like to thank all of our partners, and thank you for spending 15 minutes of your day with us to learn about this important initiative to improve the lives of older adults in long-term care.